Colleagues, let's start our GIT and genitourinary cases today. Please, one advice for all of the candidates today, please concentrate and don't satisfy of self. Okay? Uh, Candidate one, this is a
Yes, sir.
45-year-old male patient complaining of abdominal discomfortable and
Okay.
irritability, confusion, and dizziness. Go
So
on.
I have to scroll. Yeah, yes, I can scroll the images. So these are the non-contrast images of this patient who is presented with abdominal pain, irritability, and discomfort. I would just quickly go through the entire stack of images before giving my final comments. Um,
You didn't request a control.
so I'm not able to, sir, like if it is
Okay, okay,
possible. Yeah, sir.
okay.
So these are the non-contrast images. In this, I noticed that in the left kidney. Okay, sir.
Yes.
Yes, sir. Okay. In the left kidney, I noticed that there is a large hypodense lesion noted, most likely cystic lesion with peripheral calcification seen in the left kidney, which is causing compression over the adjacent renal parenchyma, also displacing the surrounding bowel loops. Also, I can see that there is um, some, okay. In So, can I see the contrast images if available for this patient? This could be a Okay, so on these post contrast images, I'm just looking at the post contrast images in which, uh, I, okay, I think the cystic lesion has mild post contrast enhancement. And in my routine practice, I would also check the renal veins. I would look at the left renal vein. Sir, sir, I think there is some. Sir, I think that this cystic lesion has continuity with the tail of pancreas. So, in my routine practice, sir, it could be a cyst, which is, however, so I would like to see the MPR images if available to know whether it is arising from the kidney or from the pancreas. However, it is making a claw sign with the kidney. Most likely, this is a renal cystic lesion. However, I would like to see the MPR images if available for this patient. Rest of the visualized abdomen appears normal. There is no pleural effusion seen. The liver and the spleen appears unremarkable. And the patient has
No,
presented with abdominal pain and confusion.
no
Uh,
NPR images. Do you want to do anything else?
uh, sir, if I would like to know if there are any ultrasound images available, or I would proceed with the MRI for further characterization of the lesion. Okay. So these are the T2 weighted MRI images of this patient, which further redemonstrates that there is a heterogeneously hyperintense mass lesion, well-defined lesion with hypointense rim noted in the left, um, on the left side of abdomen, upper abdomen. I would just quickly check the organ of origin from where it is arising. It has some hyperintensities noted. Um, Sir, I think this is most likely arising. Yes, I think this is arising from the left kidney, upper pole of the left kidney, most likely. Um, can I have a look at the post contrast images if available for this patient? Uh, okay, so these are the post contrast T1 weighted images. So this is not showing, the lesion is not showing any significant post contrast enhancement. Um, and there is another cyst noted in the lower pole of the left kidney. Okay. So, can I have a look at the pancreas, please, sir? The visualized pancreas appears normal. There is no PDF, though there is no dilatation of the pancreatic duct seen. So this lesion is making a claw sign with the kidney. So most likely this is a renal cyst with calcification with no significant enhancement. Seen, this could be a Bosniak type uh, two cysts with faint peripheral calcification. Um the patient has presented with abdominal pain. I would just quickly check the other sites to look for any. Mm, so the liver is appearing normal. There is no intrahepatic biliary dilatation of the biliary radical seen. The spleen is normal. The right kidney is also appearing normal. The pancreas is normal. So this is not likely a pancreatic cyst. This is not a pancreatic cyst. This is a renal cyst only. And rest, I'm not able
Good.
to see any fluid. There is no dilated bowel loop seen. So,
What
so I
else?
think
What else?
so. Um, I think so. There is some thickening noted in the right iliac fossa. Um,
Concentrate in these slides, please.
okay, sir. I think so. There is some filling defect noted in the IVC, sir. And I can
What
see that there is
else?
some. So there is some.
What else? Look here, doctor. What happened?
Okay, sir. On the left, in the lower pole of kidney, there is one more cyst noted in the lower pole of kidney, and
Okay.
uh, and so there the cyst also shows some. There is also hyperintensity noted in these are. So
Hmm.
the cyst in the upper pole cyst has some hyperintense signal as well. So could be hemorrhage, sir.
Please
Mm,
have a look here. Please look here. What do you think?
so sorry, sir.
What do you
So
think?
mm, sir, I'm not able to. I mean, sir, all I can make out is the cyst, the kidneys, and mm,
Look here. This is diffusion. What happened for the lower cyst?
okay, sir. Sir, in the diffusion weighted images, the lower cyst is showing diffusion restriction on the lower on the yeah
What
post
does it mean
diffusion.
for you?
So
What
that
does
means
it
that
mean?
yes, sir, this malignant changes. So this is in keeping with RCC, so renal cell carcinoma. So I would like to see the enhancement again. Uh, like I would like to coordinate this with the enhancement pattern once again. And so this
Which
is the upper pole cyst is
which phase do you want? Which post contrast phase do you want?
so arterial phase, sir.
This is arterial phase.
So I would just quickly check the lower pole cyst for any enhancement. Uh, so I think so. Yes, this assist is not visible on the post contrast. Probably, so the upper pole cyst is not showing any significant post contrast
What
enhancement. So,
else? What else?
oh, so I would look for the hypervascular metastasis in the liver, sir. Liver metastasis. In my routine practice, I would also check the metastasis in the
What's your final
lungs.
diagnosis, doctor? Doctor,
So,
what's your
sir,
final diagnosis?
this is a renal cell carcinoma with this is a renal cell carcinoma, and in my routine practice, I would check the liver for any hypervascular metastasis in the liver and also the lungs to look for any metastatic lesions in the lungs, and also I would check the bones to look for any. Uh, yes, I think there is a nodule noted in the cyst as well, sir.
Hmm.
Most
If you want
so.
to take a, if you, could you tell me the aspect or the direction of biopsy for this lesion?
So I would
Which
like to go
direction?
from, so post,
Hmm.
sir, I think posteriorly, sir, posteriorly, I can go from the posterior aspect, sir, posteriorly, sir, and
Okay. Thank you, doctor.
sir, here, sir,
Let's take,
from posterior
yeah,
aspect,
yeah,
sir.
yeah, yeah. Let's take some home message. I told all of you many times when the examiner presented a very obvious lesion, don't trust him. There are something else hiding. Look here, what happened in the CT. You are looking and then you find very large cystic peripheral calcified lesion. So it looks like cyst. Then you must search for something more critical. If we go down here in the periphery, look here, irregular, non-uniform peripheral enhanced cyst. That is the key of this case. Look, It is little bit exotic. And by the way, some the examiner will not give you sagittal or coronal, only on sagittal. And so our center is not this one. This is audit, nothing, simple cyst, calcified cyst, nothing else. Look here, one, two, three, at least pancreatic cysts. Okay, and then look here, what is this? What is this? This is not the artery or the vessel. Why? To check 100% sure, follow the artery. This is the SMA. Follow. Oh, okay, this is not the SMA. Okay, follow. Then this is by the way the arterial, but you can follow here. This one SMV, which is not enhanced at all. So it is a pancreatic enhanced focal lesion, endocrinal tumor, neuroendocrinal tumor. So from the CT, so in my opinion, you must not shift from CT to MRI before you squeeze and smudge it completely. What does it mean? You here saw a cyst which looks like something simple, something not a case for board, Arabic board, or of for FRCR. So search for something else. What does it mean? This one, RCR, RCC, sorry, renal cell carcinoma. At least as a professional diagnosis, go up. Doctor, there are few pancreatic cysts and there are an enhanced focal lesion in the ancillate process and another one here. So, doctor, I'm worried about von Hippel-Lindau syndrome. Okay? Don't leave, don't leave your CT before you mention the main pathology, three main pathology, and they give a considerable or a logic differential diagnosis. I think if I am examiner, I will finish this case at this stage. If you told me like this, no need for MRI. However, if you pick up two finding, okay, like the pancreatic cyst and the RCR, and you ask for MRI, it is acceptable. What does it the MRI mean? Look here, and this is what I give at the beginning. Besides this lesion, there are another lesion here. And what else? Look here at the pancreas. Look, one, two, three, four. At least you must ask the examiner for the 3D volume rendering. Why? To rule out is this cyst communicating with the main duct or with the side duct or not? Why? To rule out IBMN. Okay?
Yes, sir.
Okay. To rule out this one, doctor, I'm not sure is this IBMN or not. No, it's not a big issue. At least there are some cysts we are in a doubt. But here in the fusion, why we request the MRI? This is very uh, important point. We request the MRI to rule out the soft tissue component, frankly. So you must concentrate in diffusion and you must concentrate in post contrast. This is your target. And by the way, the examiner is assessing you from your requests and from your style. Is this doctor practice radiology daily, or just he gurgle some information he get? Okay, what happened here? What happened? This is the MRI post contrast. This is the arterial, I think. This is the port. At least in the portal, you can detect. Look here, the cyst, the larger cyst is completely show no any soft tissue component, no any enhanced soft tissue component. So we must concentrate with this one. Look here, look here. There are non-uniform, thick enhanced wall. At least you can give this Bosniak 4. It looks like malignant. And confirm your diagnosis here. See, there are restricted diffusion which you can prove by the EDC. And what else? Look here. At least look here, doctor. The periphery is restricted. The center is cyst. Okay, acceptable. So there are a peripheral solid component or mural thickness. What else? Look here again in the arterial. What else? What happened? Look at the pancreatic head. Look, this one. I know it is very confusing because it is very near from the vessel. One, two, one, two. So it is a case of a von Hippel-Lindau syndrome. We must tell the examiner, doctor, I want to do an MRI of the brain and cervical spine with contrast. Why? To rule out this lesion. Look here. What happened here? Cystic lesion with mural vividly enhanced nodule. What is this? Hemangioblastoma. So, complete signs and the criteria of von Hippel-Lindau. Von Hippel-Lindau, one of the phacomatosis. What is the phacomatosis? Phacomatosis are syndromes which contain neurocutaneous manifestation, like in F1, in F2, phacomatosis, Weber, and whatever else. Okay. By the way, it is not an easy case, but very good case. My advice for all of you, please don't shift from the CT to MRI or even from X-ray to CT before you smashed and squeeze the exam, and at least you must pick up 90% of the finding. Okay? Why? If you go for the MRI only to check if there are mural thickness or mural nodule here, it is very, very difficult for you to find other lesions. Why? Look here. I think this nodule is more obvious in the CT than in MRI. Look, because the spatial resolution of the CT is more and higher. What mean by spatial resolution? The ability to show you the details. Okay, so don't shift from CT or from modality to modality before pick up most or all of the findings. Thank you, doctor, so much. Next
Thank you.
candidate.
Yes, sir.
Next candidate. Welcome.
Yes, sir.
40. Can you
Sorry, can
request
you
the
scroll
control?
for me?
Yeah,
Can you
yeah.
scroll for
40-year-old.
me?
Okay. 40-year-old male patient complaining of severe epigastric pain and hematemesis.
I have been presented with CT abdomen, axial cuts with contrast. I will scroll through image before I convey my finding. Okay. The most striking abnormality is lucency at the level of the anterior to the liver and at the subdiaphragmatic area,
Yes.
suggestive of pneumoperitoneum. I would
Yes.
like to check in lung window.
Check or confirm.
I would like to confirm one window. On
Here
lung
the lung
window, on
window.
lung window, yes, on lung window. I can see lucency around the IVC and anterior at subdiaphragmatic area and anterior to the liver.
Okay.
I would like to go again for the soft tissue window, looking for the area of
Which phase do
rupture.
you want? Arterial or venous?
Venous. I would like Venous. Okay, this is the Venous study. The stomach appear distended with contrast, no air lucency around. There is
Stop
at
me
area of the
at the slice of interest for you. Okay.
okay. Can you go up again? Here. Sorry, can you go
Up or down?
down again? Yes, here I can see air lucency adjacent to the first part of first part of the duodenum
Okay.
with some wall thickening. So
Yes.
my first impression is duodenal rupture and to be perforated duodenal ulcer with
Yes.
free air.
Okay.
Can I would like to check at the uh, up at the esophageal region also. Okay, esophagus look normal, no adjacent air lucency, no
So
significant
what's your
pre-fluid.
final diagnosis, doctor?
My final diagnosis is perforation at the second part of the duodenum,
Yes.
likely due to perforated
Are
ulcer.
you sure second part? 1 second. This
First
part
part.
is the second.
First part.
Yes.
No, first part. Sorry, first part of
Okay.
the duodenum. Yes.
Okay. So
So I will urgently convey finding to referring physician and advise urgent surgical consultation.
I have one
No
question.
significant.
Could you see anything in the liver?
I can see a hypodense area adjacent to falciform ligament.
Yes.
I would
What
like
does
to
it
check
mean for
again
you?
could be just focal fatty infiltration. I would like to check in arterial phase and delayed phase to be sure.
This is the delayed phase.
Mhm. Delayed phase, there
Okay.
is no, yes,
And this is the
the
arterial
arterial,
phase. What's your diagnosis for the
yes.
liver lesion?
Can I check again?
It is only seen in the venous phase.
Yes, yes.
What does it mean for you?
Mm, on delayed image, there is no, so could be a hypo-enhancing lesion.
Yes. Does it
This
mean abscess infection because we have some perforation?
No, it's not abscess. There is no significant peripheral enhancement on both contrast study.
Okay. Okay.
Uh,
So what does it mean? What is the name of this lesion?
I think this is just fatty
No,
infiltration.
this is a pseudo lesion, my colleagues.
Mhm.
What does it mean? There are some venous drainage here which is different from rest of the liver. So it is only seen or almost seen very obviously like this in the venous phase. Why? Why? Because it drained to, I think, to vein called saperi, something like this. Anyway, this is a pseudo lesion, very common in this location, very common around the fissure in segment 4 and the hypodense. Okay, you will not see it in arterial, you will not see it in delayed, so it is a pseudo lesion. Anyway, thank you so much. What happened? What is the moral of this case, my colleague? Here, when you are shifting from, as per our great Dr. Smain Said Smain advise us, when you are shifting from chest to abdomen, here, look here for any minimal pneumoperitoneum, and that is the case of today. Look, very minimal. Even it is not well seen through the lung window. I think it is better seen here. Look, and this is the key. I think any one of us, if you miss this foci of air lucency, you will not pick up the site of perforation. Second point, you did very well, doctor, when you searching
Thank
for
you.
the most common site of perforation. Here, what is this? What happened here? This is the stomach. This is the antrum. Okay, this is the antrum, and this is the site. You can see antrum first bulb junction. Okay, because in axial you are not totally يعني aware by the exact anatomy. If you told the examiner this is first part or part acceptable, distal part of the pylorus, okay, acceptable.
Pylorus.
Anyway, this is the site. How could we detect the site? The site of maximum edema, see, and surrounding air foci. So it was a perforated, look here, my colleague, perforated gastric ulcer. Very important. One of the emergency cases, because see my colleague, I see many of the perforated gastric ulcer after, I think 4 hour or more, the pain started to localize in the right iliac fossa. And the patient I see in my career twice, and it was misdiagnosed as appendicitis. So you may be presented with right iliac fossa pain with normal appendix, and you should go up to rule out any pneumoperitoneum and perforated duodenal ulcer. Thank you, doctor, so
Thank
much.
you.
Next candidate. By the way, it was a perforated gastric ulcer because as I told you, here you can tell the examiner first part of duodenum or pyloro first part junction, not a big deal. Thank you so much. Next candidate.
Yes,
Next
sir.
candidate. Welcome.
Thank you, sir.
Could you welcome? Could you request control, please? This is a 60-year-old female patient. 1 week follow-up CT following emergency admission for an abdominal pain and distension and nausea. Can you request control? Can you request
So
control?
can you scroll for me, sir?
Okay.
So I'm presented with a post-contrast CT of a patient who presented with nausea and distension after emergency. I'll scroll through the images and I'll convey my findings. So as I scroll through the images, I can see there are multiple air-filled out pouches.
Hold me at the slice of concern for you.
Okay. This slide, please.
Yes.
So I can see there are multiple air or gas-filled out pouching, epicentered on the large bowel, mainly on the sigmoid colon. Can you scroll up again for me, sir, please?
Scroll up or down? This is up.
Yes. Okay. So I can see there is a heaviness and stranding surrounding these air or gas-filled out pouches. I can also see, so can you please scroll down as I see? I can also see there is fluid attenuation surrounding one of these gas-filled out pouches. So my provisional diagnosis here would be acute diverticulitis, complicated by perforation.
Okay.
So I'd like to check the rest of the abdomen to see if there's any abnormality of the other organs. I'd also
Up or
like to
down?
see up, please. So as I scroll, I can see the heaviness and the stranding is localized in the pelvis. The rest of the large bowel also show out pouches. However, there are no related collections. I can't see any abnormality related to the vessels either. I also like to see the inferior mesenteric vein to see if there is any associated inferior mesenteric vein thrombosis. So I'd like to scroll through the inferior mesenteric vein, please.
What's your final
I can see.
diagnosis?
So my final diagnosis would be acute diverticulitis complicated by perforation with the fluid attenuation collection in the pelvis. I'll urgently convey these findings to the referring physician as this is an emergency. I'd like also to I also would like to this patient would likely need surgical consultation for possible management and exploratory laparotomy.
Yes.
So surgical consultation is urgently needed.
Do you want to add anything?
No, sir. I also would like to add if there's any rule for the IR for the possible drainage of this collection.
Thank you,
I
doctor,
like
so
to do.
much. Thank you so much. But take a home message. See, first of all, my colleague, don't shift from the slice of interest or a slice of the pathology before examining everything. Uh, we are, as a radiologist, we are trying to pick up not only the pathology, we are trying to pick up also the cause, I mean the etiology, and the complication. Doctor, what is it? What is the name of this structure? This one.
Yes, I can see there is the air as well here and the
Where? Yes, yes. Where? What is the name of this structure? Could you tell me if you remember the patient is male or female?
it's a female.
So what is the name of this structure between the rectum and the urinary bladder?
Yes, there's air here as well within the uterus.
Okay.
So there
What
might be
does
a
it mean for
fistula.
you?
This
Yes.
might be a fistula.
Where? So you must ask the examiner for other MBR, sagittal, coronal. Okay?
Yes.
Sagittal coronal.
Okay.
Why? Because if to rule out anything else, rule
Okay.
out any complication. Look here, it is very easy here. Very easy. Endo uterine air lucency. Tell me, please, where is the exact site of fistula? This is okay. This is perforated diverticulitis with abscess. Okay, but how does it bring the air inside the uterus? Look here. I think in the axial is more easier. What do you think this is fistula connected with the vagina or with something else? Look here.
I
What is
think
the
it's
name of this
connected.
structure?
Yes, I think it is connected to the. I think it is connected to the vagina. Yes.
Not the
I think
vagina, doctor.
they.
No, 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 no. See, look. This is the vagina.
I think
The
it would be
abscess. The
better
abscess.
appreciated in sagittal view.
No, one second. The abscess is very high from the vagina. It is, see, at the fundus. What is the name of this structure, of this tube? This tube.
uterine tube.
The fallopian tube.
Yes.
So it is a fistula between this abscess or perforated diverticulitis with the right fallopian tube. Okay, look, this is the right fallopian tube. Okay,
Okay.
doctor.
Okay.
Doctor, w- if you wanted to tell the IR or the interventional radiologist your opinion, you think or you don't think this, at least this abscess can be drained by ultrasound guided or CT guided. Is there are any benchmark of the size of the abscess?
I think this abscess, I think the size of this abscess, if it is more than 5 centimeter, it could be tackled by possible CT guided tube drainage. As here, the urinary bladder would be difficult by ultrasound. The urinary bladder would be in the pathway of the tube.
Yes. So the best from your opinion, but
Posterior
see,
approach.
posterior approach is very difficult here. There are many veins here, many nerves. So he may drain it from this direction. Okay. But anyway, he has fistula. I didn't have enough surgical experience to rule out. But I think this patient may need surgical drainage and surgical repair for the fistula, something like this. Anyway, the most important for us, hello?
Yes.
The most important for us, don't satisfy of search. Please don't satisfy of search. Thank you, doctor, so much.
Thank you.
This case was a fistulizing diverticulitis. Fistulizing diverticulitis. My colleague take care from all the inflammatory process in the pelvis because almost it is associated either with fistula, okay, whatever the nearby organ, or mesenteric venous thrombosis, or metastatic hepatic abscess. So try to squeeze the exam in front of you to pick up the maximum number of pathology and the complication. Thank you, doctor, so much. Next case, next candidate. Take care, my colleague. I will repeat again. Today, cases of satisfaction of search. Don't satisfy of search. I know. See, who the candidate who is in the hot seat. It is very difficult, by the way, not easy for him to get more and more pathology. Okay. Doctor, this is 14-year-old male patient presented with acute right iliac fossa pain and fever. Go on.
Okay, sir. Yes, I'm provided with a CT scan of the abdomen without contrast. So can you please scroll for me? It's not scrolling.
See, you can use the
So
arrow. Use the arrow.
yes.
Use.
Yes, sir.
Hello. Hello.
So can you hear me?
Yeah. Use the arrow.
There was, yes. No, sir, it's not. Sir, please scroll for me. It's not actually jumping, and
Okay.
I can see there is right-sided mild pleural effusion with underlying subsegmental collapse. This is a patient for a young patient, 14-year-old male who has presented with pain and fever in the right iliac fossa. So I can see that there is fat stranding in the right iliac fossa.
Stop me at the slice of the wrist for you.
Okay, so please scroll up. Yes, here, sir, here I can see that so the pelvis, yes, sir, so a bit down. I can see that the
Down or up?
down, sir. Down, more down, sir, more. Here, sir. So I can see that there is an blind-handed tubular structure within the pelvis with thick walls, and it has internal echogenic, hyperdense foci. So this is likely inflamed appendix with the with appendicolith within it. And I can see that it is distended, the lumen is distended, and it has internal fluid that also appears to be slightly hyperdense. And I can see there's marked peripheral lesional fats trending, as well as I can see fluid in this region as well. So could you please scroll a bit up as well? I can see there is a subtle thickening of the adjacent bowel loop as well, likely due to the inflammatory process. And I can see that there is a fluid in the hepatorenal pouch, as well as in the right iliac fossa. Yes, sir. Could you please scroll down now? I would like to rule out the perforation of this. So I would like to, in my routine practice, I would also like to see the lung window. A focal area of, sir, please scroll up a bit again. Up.
Do you think it is preferable to rule out perforation in non-contrast?
Sir, sorry, sir, please repeat the question.
Did you think it is better to rule out a perforation at in non-contrast window or non-contrast CT?
No, sir. Ideally, we should have contrast, but sir, in emergencies, at some time we have patients that are
No,
not.
I advise many times before ask the examiner. Okay.
Okay, sir. Okay,
Mm.
okay, so these are contrast images of the same patient, in which I can see that there is enhancing demonstration of the similar enhancing tubular structure in the right iliac fossa with adjacent bowel wall thickening. And sir, there is another tubular structure that is showing communication with the small bowel. Here, sir, yes. And it also shows mural enhancement. Here, yes, sir, this one. Sir, this is also blind-ended. So, sir, sir, this could be, sir, in young patients, we have, we can have another tubular blind-ended structure that arises from
Are you
the.
sure the second one? Are you sure the second one is blind-ended? Look here.
Okay.
Look.
Okay. Yes, sir, please, can you scroll up? It shows mural enhancement.
No. Concentrate in this. Concentrate, please.
Yes, sir. So there is a tubular structure, yes, that has enhancing wall and marked perilesional fat standing and adjacent bowel loop thickening as well. Small bowel loop, marked circumferential thickening of the bowel loop is also seen. No, sir, no, sir, it is not blind-handed. It is not blind-handed, sir. It communicates with the bowel, and I can see that the small bowel feces sign is seen just proximal to this narrowing of the small bowel loop. So likely, sir, there is an dilated small bowel loop with the fluid levels, and that is the transition point. That structuring and narrowing of that loop is likely the transition point that is causing obstruction and proximal distension of the small bowel loop, along with the appendiceal wall thickening as well. So, sir, this is likely an inflammatory process. So, possible differential in this case include, sir, Crohn's disease, and other than that, this could be infective etiology like tuberculosis. And I would
What's
like
your
to.
final diagnosis?
So this is an inflammatory process that is involving the long segment of the bowel and causing thickening and stricturing of the small bowel loop, likely the the ileal portion, and is causing proximal small bowel obstruction and.
Okay, but what about this structure? What
So
about
this is like.
And second question, do you think Crohn's disease will cause a fever? And the third point, do you think
Yeah.
Crohn's disease will cause this effusion? What does
No,
what
sir.
does
Sir, it
it
is one of the
mean?
differential. Likely, this is infective etiology, sir. That is leading to this thickening and small bowel
Doctor,
obstruction and narrowing.
this patient came in the emergency and the surgeon want a report like yes or no. open,
Okay, so I would like to,
not open, close-ended report. Okay.
okay. Sir, I would like to see the upper abdominal images as well to rule out any other etiology or any other. Okay, I cannot see any ear within the biliary, within the portal venous ear region, and I cannot also see free ear.
What's your final diagnosis? No more time
So,
allowed.
okay, so this is a small bowel obstruction likely due to an inflammatory structure involving the small bowel, and this is likely a fecolith or appendicolith with associated inflammatory process involving the appendix as well.
Yes, like this. Thank you so much. What happened here, my colleague? What happened? This is the appendix. From the beginning, the examiner gave you a very good clue. 14-year-old, acute right iliac fossa pain and fever. And you find this appendiculus or whatever, not appendiculus, calcified or stone. Follow it, follow. You will see a blind-ended structure. This one is 100% blind-ended. Okay? With perforation here. Why? No wall here. And there are fluid and fossae of air. What does it cause? It is very near from this distal ileum. Distal ileum is markedly enhanced and thick with and attenuated caliber with proximal fecal sign and IO, intestinal obstruction. So your final diagnosis should be, and see besides that, see, what is this? Fluid. A very big evidence of the perforation. You make a mistake, doctor, when you didn't ask me to help you with other orthogonal views or other MBR view. Okay, and really the examiner will not give you anything you didn't request. If you request from the beginning, I think you must finish the case in half of this time. If you look here, my colleague, look. What is this? Typical appendicitis. Look, typical appendicitis. Somebody may told me, doctor, and see the defect here. Somebody may told me, doctor, it may be a gallstone ileus. Okay. Despite this is unlogic diagnosis, but go up here and search for pneumopelia, non-pneumopelia. Okay? And the gallstone ileus will not cause this severe inflammation. So what is the diagnosis here? What is the diagnosis? Perforated acute appendicitis, complicated with terminal ileitis here, terminal ileitis, and this terminal ileitis result in IO. Okay, my colleagues, for surgical urgent appendectomy. Is it clear for all of you, my colleagues?
Yes, sir.
Hello?
Yes, sir.
Okay. So take a home message. The pathology is here. Don't confuse yourself. Trust in your eyes. This is first point. Second point, don't tell unusual differential diagnosis. Why? Look here. This is very blind-ended. This one is a tubular structure connected with the rest of, look. This one connected with the rest of a small bowel. This one. Okay. Sometimes we didn't trust our eyes. Why? Because you may be presented with unfamiliar case, non-familiar, and we are worried. No. This is not appendicitis. Like also the case before. No. This is not RCC. From now, consider you must be presented with one or two cases with atypical pathology or atypical scenario. So trust your eye. Describe what you are seeing. This is all. Thank you, doctor, so much. Perforated
Thank you, sir.
appendicitis complicated with IO and terminal ileitis. Next candidate.
Due to some reasons, candidate 5 is not going to join. Candidate 6, please proceed.
Yes, sir.
Welcome. This is not gallstone alias Dr. Rania. Why? I just explain why. At least search for pneumobilia. At least. Second, the gallstone alias will not cause this severe surrounding inflammatory process. Third, this is inside a blind-ended structure, which is the appendix. Three reason that is why the last case was not gallstone alias. Doctor, this is 60-year-old male patient presented with frequency of urine and nocturia. Go on. 1 second. Go on, doctor.
Okay, sir, I have requested control.
Yeah, I approved it.
Okay, sir, still it is okay. Okay, I am presented with the T2 sagittal slices of the MRI pelvis, and okay, 1 minute. I want to look at the findings before commenting. Sir, it is not scrolling properly.
Let me scroll for you.
Okay. On this, I can appreciate that the urinary bladder is mildly distended, and there is thickening along the walls of the urinary bladder with likely a soft tissue mass. The mass appears to be T2, slightly low signal intensity. I would like to see it on the other provided views, coronal. Okay, I can see that the prostate gland is heterogeneous, and the urinary bladder. Okay.
Stop
Okay,
me
there are.
at the slice of interest for you.
Sir, first of all, I would like to see the urinary bladder, then I will focus on the prostate. Okay, I can see that there is a long segment circumferential mucosal thickening, which is involving the left lateral wall of the bladder predominantly. It is it is showing T2 intermediate signal intensity, and I am okay. The wall of the bladder anteriorly appears quite thickened and is of T2 low signal intensity. I am suspecting that keeping in view the age of patient, this is a suspicious finding, and I would like to see its extent. Sir, can you scroll up and down? Okay. Okay, sir, again back up. Yes. Okay, so I can see that this lobulated thickening is separable from the prostate gland, and I would like to see its upper extent. I can feel that the upper extent of the lesion is yeah. Okay, so here at the superior most extent, I can see that it is breaching the muscularis layer as well as the serosa of the bladder and is going into the perivesical soft tissues. Okay, I can also see that it is causing invasion of the left-sided ureterovesical junction, and there is dilatation of the left distal ureter. Um, so I'm thinking more in the lines of aggressive etiology, likely a malignancy which is involving the bladder. And I'm looking at there is a perivesical fat stranding as well. Okay, so I'm looking at the lymph nodes, which I do not appreciate significantly in large lymph nodes. The fat plane with the rectum appears clear, and the seminal vesicles demonstrate demonstrate the T2 normal signals. Now I would like to see the prostate gland also, because I thought that there was something abnormal in that too. Okay. So I can see that there is a diffuse T2 low signal intensity, which is involving the right half of the prostate gland. It is also involving the peripheral zone as well as the transitional zone. And I would like to see it, okay. Okay, so I would like to, I'm thinking that there might be a concomitant malignancy within the prostate gland, but I would like to see it further on the dynamic and contrast enhancement studies to look for any to look for the to check for the malignancy within the prostate and to stage it further. And so can you show me the, okay, I can also check the diffusion restriction sequences. Okay, I can
Yes.
appreciate that there is a DWI, high signal intensity, involving the peripheral zone of the prostate on the right side. I would like to make it. I would like to correlate with the ADC to check its low signal intensity. Okay. Sir, here okay. Okay, yes, there is a corresponding ADC low signal intensity in the right peripheral zone of the prostate. So this is most likely in keeping with the malignant etiology lesion. So it will be categorized as Pirates 5. I would like to I would like to describe my findings in my report to the referring physician. And I would like to refer this patient for the urology MDT discussion, because we are thinking on the lines more of two malignancies, one in the prostate and one in the urinary bladder. And I would also like to ask the history that patient has a known malignancy of bladder or prostate before.
Yes, he has high BSA.
Okay, so patient already has okay, so patient is having a prostate malignancy, and the second malignancy within the urinary bladder is most likely to be a TCC, transitional cell carcinoma. I would also like to inquire about the history of any previous radiation which might have led to this concomitant malignancy within the urinary bladder.
Do you think there are only one suspected focal area, malignancy area, at the prostate, or more than one area?
Sir, one, I can see that one is located in the right peripheral zone, and there is another one also located in the transitional zone on the left side.
Excellent. Thank you, doctor, so much. Thank you. Thank you. What happened in this case? The doctor, I give her this one. This is I think I started with this one. She pick up this mural technique or mass. Okay? No worry. No doubt this is a malignancy here. But the trick, leave the mouse, please, doctor. Leave the mouse.
Yes, yes, sir.
The trick is here. When you are searching in something like this, you finish the bladder. Very clear there are mural thickening, or there are mural mass, which is completely the signal here is totally different from the muscles. The muscle here is dark because we are in T2. Here is slightly bright, more than this muscle. Okay, so this is a tumor. And okay, she pick up some extra luminal extension maybe here. Okay, very, very acceptable. But what about this one? Very important. If you miss to tell the examiner, okay, doctor, there are maybe some extra luminal extension and يعني subsequent left hydroureter, but don't forget this one. This is very, very important. Don't miss this one. What happened here? Doctor, what is the most important for the peripheral? See, my doctor, this is the peripheral zone, and this is the central or transitional zone. Transitional zone. Doctor, what is the most important sequence to detect peripheral zone prostate cancer. Choose only one.
Sir, peripheral zone is T2.
Okay. What about the transitional zone? Give me
Sir,
only
ADC.
1 second. What?
Sir, ADC.
ADC. Could you reverse both of them?
Okay,
This?
okay. I forgot, yes.
No problem. My colleague, peripheral zone, the most important is the DWI, diffusion. But the central, or sorry, the transitional zone, the most important is T2. What does it mean? Normally, the prostate, this is the peripheral zone. Okay? This one. Normally, it should be bright like this one in T2. Look here, there are very dark, and there are big difference between here, my colleague, and here, between this one and the left side. Why? Despite the left side looks have some foci of low T2, but it is ill-defined and heterogeneous. But look here for this one, it is markedly dark T2. And this is very important. When you see markedly dark T2, I'm talking as a general rule in prostate. Markedly well-defined and dark T2 is highly suggestive of malignancy. Markedly high diffusion, sorry, is highly suggestive of malignancy. This is very important. Why? Because there are many grades of pi rate for prostate. It depends, especially to shift from 4 to 5, according to the size, and if it is markedly high diffusion or not. Look here, very obvious, very obvious. This one, and I think I have a doubt about this one. Okay, my colleague, the most important here to know that 1 second, I will show you very, very important, sorry, very important image now about the prostate. 1 second. The prostate is 1 second. Look here, my colleague, this is the prostate. The prostate is inverted pyramidal shape. The apex is down, the base is up. Okay? It consisted of peripheral zone and transitional zone, and this one is, I think this is central zone. When in BBH, this one enlarged the transitional zone and causes atrophy for the central loop, or this one. Most of the malignancy, okay, this is a TS or an axial. One here at the upper part, at the middle part, at the lower. Okay, my colleague, what happened? We divided each zone to many other zones. What is this? Let's look here. This one. This is the peripheral zone. Okay, this is the transitional, and the more and the most anterior, this one is the fibromuscular stroma. This is not a site of malignancy. So the malignancy here almost in the peripheral zone, sometimes here in the transitional zone. This is the most important for us as a beginner in prostate. The peripheral zone divided into right and left. Each one of them, this is right anterior, this is right posterior. This is left anterior, this is left posterior. Each posterior one has medial segment or portion and lateral posterior portion. The transitional zone is either anterior and posterior, right anterior, right posterior, left anterior, left posterior. This is very important to specifically name the size, the site of malignancy. Okay, and you will tell the examiner or your colleague, urology colleague, doctor, this is in the upper prostate section, peripheral anterior, right peripheral anterior, or this is in the middle part of the prostate, right peripheral anterior, or this is in the lower section, or okay, right peripheral zone anterior part. This is the correct segmentation of the prostate. Okay, my colleague, is it clear for all of you? At least we get up today some little bit information about the prostate. If you want to examine the prostate, first catch the ADC. This is very easy way. Catch the ADC, okay? And look for any low ADC signal. This is low ADC. This is the most easy. Look, click. Oh, I suspect this one. Okay, this is posterior, I think middle. This is posterior, right, posterior zone medially. In the middle part, check in the diffusion, DWI. This is the DWI. Okay. Oh, okay. The suspected area is highly restricted diffusion here. So it is sure malignancy. At least give by rate 5 and you are 100% sure. Is it clear for all of you, my colleagues?
Yes,
Is it
sir.
clear? For the central zone, this is as a general law to facilitate, to make it very easy. Also, I will see something here. Oh, I'm big doubt about this area. Check here. Oh, very bright here. Okay. In transitional zone, you must confirm your finding in T2. The T2 in the transitional zone is more important than the diffusion. Look here, markedly low T2 and very, very well defined. I think this is called erased charcoal sign. I think this one. Okay. At least you can give by rate 4 or 5. And at least 4, and you will see the size. There are a large table full of details. The pyrates of prostate pyrates, PPEN, is the most detailed pyrate one, more than the thyroid and the breast and everything. And I think it need always to be in front of you when you are reporting any prostate case. Very interesting case. And I'm so happy that I presented one prostate case with some tips and some anatomy. Next candidate. Next candidate.
Yes, sir. Can you hear me?
Yeah, good. I will scroll for you to save the time. Doctor, this is
Thank you so much, sir.
70-year-old female patient presented with right upper quadrant pain. Go on.
Okay, sir. Okay, sir, I have been presented with the ultrasound images of the right upper quadrant. On these images, I can appreciate that there is a large hyperechoic mass lesion, which is appreciated on the upper pole of the right kidney. It shows vascularity on the Doppler study. It appears to be rather well defined with slightly ragged and irregular edges along the upper pole of the right kidney. There are no internal calcifications, and I would like to scroll further to look at the infiltration of the liver parenchyma, which I think it is closely abutting the undersurface of the liver, but it is not frankly infiltrating it. So considering the anatomical location, I am thinking about adrenal lesions. There was vascularity on the Doppler study, so since it's very echogenic, and that's a feature of a fatty component, but there was also associated vascularity on it. So I am thinking that it might be a mixed density adenoma. For the second differential can be a metastatic lesion, for which I would like to correlate with the history of any known malignancy of the patient. And the third
Yes,
thing
your
I
next
would like
step.
I would like to go for either MR with the proper adrenal protocol, or I can go for a CT if that's available. Anything which might be available.
Look
Okay.
here,
Okay.
please.
Okay. I have been provided with the FATSAT sequences, and I can appreciate that there is again a mass lesion, which is appreciated on at the anatomical place of the right adrenal gland, and I think there is marked fat suppression in this image, in this lesion, with the slight hyperintensity, which is appreciated along the periphery of this lesion. No frank infiltration of the surrounding structures is noted. The thing which, sir, so I am a little bit contralateral adrenal is, so I'm thinking on the lines of that it is a lipid-rich kind of adenoma. And yes, it's a T2 sequence, and I can appreciate again that it becomes hyperechoic. But and I would like to see the contralateral adrenal gland as well.
Doctor, are you
So can I?
sure this is a suprarenal lesion?
No, sir. I can appreciate the right adrenal gland on this sequence actually. So can you scroll further a little bit up and down? Can I scroll further? Okay. Okay, it becomes perinephric. It's a perinephric in location, sir. It might be an exophytic angiomyolipoma, and I can appreciate it has slight continuation infiltration into the upper pole of the right kidney. So it might be an AML angiomyolipoma from the arising from the, it has a slight nipple-like protrusion into the renal parenchyma at the mid pole as well. So I would like to retract my statement, and I would like to go for the angiomyolipoma of the right kidney with predominant exophytic bulk, and there is hyperintensity was appreciated. I would like
Look
to
here,
go for the
please.
T1.
But
Yes, sir.
look here, most of the lesion is in the kidney or outside the kidney. How
Sir,
can
it
you
is
differentiate
outside
it
the
is
kidney.
from a renal origin or outside the renal origin?
Sir, it is giving a slight nipple-like protrusion within the kidney. And I think I read it somewhere that it is a sign of angiomyolipoma, that it gives a slight indentation or slight protrusion into the renal parenchyma. So
What's your
I
differential
am,
diagnosis? What's your differential
uh,
diagnosis of a perinephric fat-containing lesion? Okay, with
sir,
this
that can be,
something soft tissue. What else?
okay. Sir, that is, that can be a sir, malignant fat.
Hmm. Hello? Hello? Hello?
I think she lost connection.
Yes. So we lost candidate.
Sir, can you hear me?
Yeah.
Sir, yeah. Sir, that can be a metastatic deposit from a liposarcoma, might be from a previous malignancy or a recent malignancy which he has somewhere else. That can be, sir.
Give one or two clue and the final diagnosis to reach the final
Sir,
diagnosis.
sir, I think that's an angiomyolipoma of the right kidney, and I would like to go for the further work of tuberous sclerosis.
Okay, but why you insist this
Without
is
rupture. And since this is 4 centimeters, so I would also like to involve the.
hello? Hello?
Yes, sir. Can you hear me?
Yeah. Doctor,
Yeah,
give me
yes, I'm
some
so sorry,
proof,
sir.
to your final diagnosis. You told me it may
Uh,
be AML, angiomyolipoma, or maybe liposarcoma. Give me two proofs. This is one of both of them.
Okay, sir. I would like to see the rest of the viscera, sir. In the lungs, I don't appreciate any kind of cyst, sir. I would like to correlate with chest. Look for further findings of tuberous sclerosis. I am not,
Okay,
sir.
by
I
the way,
can't appreciate.
this is the only lesion in the whole exam. Save your
Okay,
time.
okay. Okay, sir, I think this is angiomyolipoma because I can see
Why?
as an
Why?
infiltration into renal parenchyma.
Why? I'm so worried. I'm the clinician, and I
Yes,
suspect
sir.
it is a liposarcoma. I insist. I look at the images. Doctor, there
Yes, sir.
are a soft tissue, large for
Mm,
my eye, not a small soft
mm,
tissue here, enhancing component in a retroperitoneal perinephric large fatty lesion. See, look,
mm.
and
Yes, sir.
how it
Yes.
hides the kidney. I'm not believe that this is angiomyolipoma. You are the radiologist
Okay.
and you must persuade the clinician. What should you tell
Okay.
him or what will you tell him?
Um, sir, uh, it has
Besides,
enhancing component, but I am
besides
sorry,
that,
sir. That,
I call one radiologist. He told me, "Oh, doctor, my this there are no claw sign, so it is looks like
hmm.
outside the kidney." So, what's your answer?
Sir, at right the image, just this one, sir, which you are showing right now, sir, the axial one. So, sir,
Yes.
on this basis, sir, I am convinced that this is AML because it is infiltrating into the renal cortical parenchyma, and it seems to be originating from that.
Mm.
That would be my most probable answer to the clinician, sir. Um,
Okay.
so, yes, sir.
Okay. 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 There are two answers here. The first one, you told me there are a nipple sign. This is correct. Second one, look, what is this? The vascularity of
Hmm.
this mass coming from the kidney. Look,
Oh, okay,
look,
okay.
very
Yes, sir.
important.
Yes, sir.
Okay.
Hmm. Yes,
Third
sir.
point, look here. If I told you this is
Hmm.
the early arterial, look,
Hmm.
look at the enhanced soft tissue. It is just mildly
Hmm.
enhanced. Then
Yes, sir.
this is the early arterial. This is the venous
Hmm.
or the phase after that. Here, very fake, look, very fake enhancement. Then the
Hmm.
enhancement increased. Then in the
Hmm.
phase after that, progressive. There
Hmm.
are persistent progressive enhancement,
Hmm.
which a
Yes, sir.
criteria of a vascular region or vascular containing lesion. Okay.
Hmm.
And
Yes,
besides
sir.
that, no local invasion. So it
Hmm.
is exophatic renal angiomyolipoma. Okay.
Okay.
Thank
Okay.
you, doctor,
Oh,
so much. We
thank you
should
so
refer
much,
the
sir.
patient for a urologist because we are worried about rupture because this lesion is
Hmm.
larger than 5 cm. It is very large. I think it is
Yes, sir.
about more than 10 cm. I think, look, the measurement is not here. Okay. So there are
Okay.
three evidence this is not a liposarcoma. Thank you so much.
Hmm.
Thanks for
Thank
all of you, my colleagues. Thanks for our coordinator. Let's meet next week. I think there are many questions. Okay, thank you for all of
Sorry
you.
for the last
Good.
case. So can you explain the 3 points again?
Okay. The 3 point is number one, at least we follow some criteria from where this mass is supplied by blood. Look here, from the kidney, from the kidney. So it is a fat containing lesion exiting from the kidney. So it may be or almost it is exophatic AML. Next, this is the notch sign is very characteristic to the AML. Third point, if you follow the contrast uptake, this is the arterial, okay? And this is the portal. Look, more increasing. Persistent progressive enhancement, which a criteria for any vascular lesions or vascular containing lesion like hemangioma, ML, all of this. Okay, that is all. But
Thank you.
the liposarcoma is poorly enhanced. Okay, is it
Okay,
clear?
thank you.
Look,
Yes.
look. Okay, thank you. Thank you for all of you, my colleagues. Goodbye.